to say thanks again for coming and enjoy your lunch and enjoy the program. Peggy Neville is going to introduce our keynote speaker today. Peggy, come on up. Peachum Baptist.
Hi, everybody. Thank you for coming. My name is Peggy Neville. I'm the breast care coordinator at Baptist downtown at the Hill Breast Center. I am here to introduce Dr. Desai. Dr. Desai was born and raised in Jacksonville and graduated from the Bowles School. Dr. Desai received his medical degree from the University of Florida, where he served as class president for all 4 years. He completed his plastic surgery residency in St. Louis University. Dr. Desai also completed specialized cosmetic surgery training at the University of Alabama at Birmingham, under the direction of internationally renowned plastic surgeon Dr. Louis Vasconez. While at the University of Alabama, Dr. Desai served as a clinical instructor. Dr. Desai is board certified in plastic surgery. His interests include cosmetic and reconstructive breast surgery, anesthetic and endoscopic facial and eyelid rejuvenation, minimally invasive surgery, and body contouring. It is my pleasure to welcome not only a talented surgeon, but in my opinion, a darn nice guy, Dr. Ankit Desai.
She said she was going to read that. Peggy's known me, I don't know, about 25 years, so she could have said a lot more, and she got the scripted version down. So it's a pleasure to be here today. Can everyone hear me really quick, just with the microphone where it is? Great. Obviously, as a plastic surgeon, a large focus of my particular practice is the reconstruction of the breast when it comes to regards to women afflicted with the terrible disease of breast cancer. And I've been fortunate to work with breast care coordinators like Peggy and helping so many women at least learn or educate themselves about what their options are. I think so often the entire story is you get the diagnosis of breast cancer. The focus is all on kind of this whirlwind of, well, what do I need to do to get it out? And then, well, what kind of chemotherapy do I need? And how much radiation I need? And then, you get through the whirlwind and you never really maybe took 5 minutes or a weekend or to pause and say, well, what are the elements? What happens after all that's done? And that's really where plastic surgery plays a role, is improving not the quality of life. Because survival has gotten so much better. So many more women with breast cancer are living, and that's a testament to the medical oncologists, the general surgeons, the radiation oncologists. But really then, what kind of quality of life do we have, or what are we providing these women with as they go forward? And that's where I hope to be a benefit to women, of all walks of life, from all ages, reconstructed or helped women as young as 22 to as old as 74. It's not for everybody. Some that it's not important to them, and some it's very important. And when it's important, whether it's right after or years later, is so variable. But really, the message here is to educate you on what some of the options are, because if I was to educate on all the options, we'd be here a lot longer. But what are some of the options? What are the newest kind of things that we're doing to try to improve outcomes for women, with breast cancer? And that way, maybe you can take home that message, because so many women know somebody with breast cancer. I mean, just show of hands, how many women, at least know someone that's been with breast cancer? Yeah, pretty much everyone in this room. So knowing women and people in general, basically, a lot of it, you ask your friends for advice. And so, what did they go through, or what did I go through, or do you know what these things are? Interestingly enough, I think because of the whirlwind that's sometimes associated with breast cancer, women are not necessarily told about their options for reconstruction at the very beginning, and that's something that we need to do a better job of. I think we definitely, with the multidisciplinary breast team at Baptist, are able to provide women with, if they so choose, that they have the option, if they want to meet with a plastic surgeon, whoever that may be, that they presented that. There's actually a state law in New York now that's been passed mandating that women be told that they have an option for breast cancer reconstruction. And that's just to highlight that not everyone is being told. So kind of get into it, breast cancer, and anyone have questions, feel free to just interrupt me at any time. You don't have to wait till the end. There's a lot of pictures, so there won't be as much text, all right, as you may be used to. But breast cancer, obviously the most common malignancy in women. It's 1/3 of all cancers. Second leading cause of death in women, and there's about 250,000 new cases every year. When I see a patient, and most of what I'm talking about today is going to be what kind of reconstruction we can offer after mastectomy. There's a whole host of options, and it kind of gets a little bit more complicated and is suited to that particular patient when you talk about reconstruction after lumpectomy. But there are, just to kind of highlight, if you've had a lumpectomy, know someone that's had lumpectomy with radiation treatment, and they are not happy with the asymmetry that's been created or the way it looks. Sometimes there may not be options, but more often than not, there are certain options those women have to potentially help solve those discrepancies, like breast size or breast asymmetry. That's not going to be the focus of this talk. We're going to concentrate on post-mastectomy reconstruction because it is a little bit more common. And so when I see a woman that, either by choice, and a lot of women are opting for bilateral mastectomy, some of it's because of fear, some of it, MRI, technology is picking up cancer that they didn't necessarily see on mammograms. So when I see a patient either electing to have a mastectomy because that's just simply what they want, or that because of the size of the tumor or the nature of the cancer that need a mastectomy, I generally say, well, breast reconstruction is a process. It really is. And so the process can begin at the time of mastectomy, or it can begin any time after you're done with your treatment if you so choose. Most of the patients that opt into delayed reconstruction are either by their own choice, meaning they've gone through chemo, radiation, if they needed either one of those, and they've come back for reconstruction at a separate time. So they do it by their own choice, or they're kind of pushed into it because for the need of radiation treatment, and the results are going to be better if you wait till after. So we talk about the process, and there's generally 4 things we need to reconstruct. There's a skin envelope, so there's more. If you look at the breast from the side, there's more skin on the bottom of the breast than there is on the top. There's the gland itself, the tissue that's underneath the breast, under the skin. That's actually the part that's removed for the most part. There's the nipple, which is the projecting portion, and then of the center part of our breast, and then there's the areola, which is the pigmented portion. And we can reconstruct 1, 2, definitely 1 and 2 are part of the reconstruction of the breast, the skin envelope and the gland. And some women opt for nipple areola reconstruction, some don't. And so it is tailored to what the patient desires and what's important to them. But in general, those are the 4 major elements of what we, as plastic surgeons say, this is what we're trying to restore as whole. And if we talk about immediate reconstruction, that means that we're in there with the general surgeons at the time of the mastectomy, starting the reconstructive process. And what are the advantages? The aesthetic outcomes are better, so the cosmesis is better. There's less patchwork, smaller scars. There's less psychological trauma. Many of these women with now skin-sparing mastectomies, and we're preserving the skin envelope, they wake up either with a whole breast, depending on the technique we use, or with the start of a breast. May not be as big as they were, but they're not flat-chested, and so that eases their fears or what they thought. I just operated on a surgeon's wife, and she, until we met 3 or 4 times. Her husband's a surgeon. He talked to her about it, and until the surgery was all over, then I walked in the next morning. She's like, well, this is great. This is not as bad. The mind lets you think that things are going to be much worse, that they're going to look much worse. After trying to explain the technique, she thought that the breast was really literally just chopped off, and there was like a hole there, and so what we imagine is often a lot less severe, or it's a lot worse than what the reality is. And so you're going to see pictures, and generally we try to minimize the scarring as much as possible for these mastectomy women as we try to reconstruct them, so that when they look in the mirror, they don't see necessarily the scar from breast cancer. They see their breast, they see a sense of wholeness. And we're getting better and better at minimizing those scars, and it depends on the patient's particular anatomy. But that's one major advantage of immediate reconstruction. The scars are smaller. You're able to preserve some certain anatomical structures, and really that does add to the cosmesis of the overall result. The disadvantages are, you know, if you're having radiation treatment, you can sometimes have immediate reconstruction. For the most part, you're probably better off having delayed reconstruction for cosmetic reasons. This is just an example, and I don't know how well you can see it, but this patient had an immediate right breast reconstruction, and this patient had a delayed right breast reconstruction. And you can see there's a scar here and here all the way around. And this is where Jerry Millard within the Pink, I met with her yesterday. We were talking about why there's a big, larger scar pattern. And because of the delayed reconstruction that was radiated, she needed more of that skin envelope because it was flat when we started, and so we needed to use that skin to recreate that skin envelope. And on the left side here, you can see, you know, the scar pattern is much smaller. It's mostly hidden with the areolar reconstruction, so that, you know, you can really have improved outcomes. You know, I hear a lot from the medical oncologist, you know, that are maybe a little bit, you know, with gray hair and aging in their tenure, but that immediate reconstruction is bad, and it delays chemotherapy, and so when we look at it, you look at every major study, it says that it does not delay chemotherapy, that immediate reconstruction has a significant psychological impact on the women. 95% who had immediate reconstruction were glad that they had it. 3/4 of women that had delayed reconstruction wished they had immediate reconstruction. It adds to body image, self-esteem, and when you look at the data as far as safety, women that have immediate reconstruction, and we're talking a study on 17,000+ patients, they lived just as long, they had no delay in chemotherapy, and they had no difference in local recurrence rates. So they're living just as long as those women that didn't have immediate reconstruction and hasn't delayed chemotherapy. So a lot of that, you know, is kind of just old thinking, and trying to change that since I've moved here. Skin-sparing mastectomy is where the nipple areolar complex is generally removed, and that's been the standard of care in the 90s and the early 2000 decade. And we'll talk about maybe what's on the horizon. But skin-sparing mastectomy has been proven, as far as I'm concerned, to be oncologically safe in the right surgeon's hands. Knowing where the tumor is, you can preserve a lot of the skin, excluding the nipple areolar complex. And there's multi-year follow-up with thousands of patients demonstrating that it's oncologically safe. No difference in, when oncologically safe means there's no difference in survival and no difference in local recurrence. So that's what that means to me. Yes? You can. So so there are many women, like BRCA positive women that opt for, or even women that have had 15 biopsies. They have both of them are removed prophylactically, meaning that they've had them removed in a preventative fashion. And there's basically, when you look at it, you have a 90% risk reduction in developing breast cancer. So it is not 100%. And so when they've looked at, you know, doing preventative mastectomies, or say you have breast cancer on one side and you say, well, you know, I'm going to take the other one off, it doesn't mean you have a 0% chance of getting breast cancer on the other side. That's correct. You have a 90% less chance. So 1 in 8 women, or about 12% of women, get breast cancer. And you know, if you divvy it up between 2 breasts, 6% and 90%, you know, the numbers are a lot smaller, less than 1% chance of developing breast cancer on the other side, unless you had a genetic mutation, but it's not 0. Good question. So once we get to deciding whether we're going to have immediate or delayed reconstruction, we really say, well, I meet with the patient and we talk about whether we're going to do the next option, really, and it's either whether we're going to do implant-based reconstruction, or use an implant, or we're going to use autologous reconstruction, where we use the body's own tissue. And we present them with both the options. Some women are too skinny to have autologous or using your own tissue, you know, and so that kind of eliminates that. But we try to explain to them what all their options are, and then really, if they ask, you know, if we really are strongly feel one's better than the other, I'll make a recommendation. Or if I think they're a candidate for both, I'll let them decide what they feel is best, because the recovery times vary, the surgery times vary, the hospital stays, all those kind of things are dependent on what type of reconstruction you choose, and the only way to know those things is educate them about both. Oftentimes I think implant-based reconstruction, which I do a lot of, and I think is a wonderful tool for women to have, but you know, I know many women that I've come for revision surgery, or they've had 10 surgeries between multiple doctors, and they only had the option of implant-based reconstruction, and then they've now heard that there's other options out there, and you know, that particular physician may not do anything besides implant-based reconstruction, but I think it's important that patients are educated about what their options are, and so that if they're interested in it, they can seek out someone here or in Jacksonville or in a local community, neighboring community, on something that they want more information on, may be better for them, more than what they think they are. So when we talk about implant-based reconstruction, the most common technique we use is a two-stage approach for the reconstruction of the breast. And I'm going to just focus on that. It's when we use a tissue expander, which is kind of like a glorified water balloon, because when I see women, I ask them, well, do you like your current breast size? Would you rather be bigger, or would you rather be smaller? Most women want to change in their breast, and the goal of reconstruction, really, I mean, 20 years ago, the goal was to look good in clothes, right? So to get something up there that women could wear a bra with, and then kind of get to wear a shirt and to be okay in clothes. Now, that's not what women want now. They want to look, almost like as close to normal as possible. They want better breasts than they had before. So, and they want to make sure that they have plenty of cleavage. So, we live in Florida, and so that's very important. Women want, and that's what we're trying to provide. The goal is no longer to just fill in the bra or a stocking stuffer. It really is to have something that they can look in the mirror and they say, this looks beautiful, or that they think it looks beautiful, something that looks symmetric to the other side, or if they have one or two sides. It's not just to fill out clothes, but something to look good in the mirror. Yes. So the transplantation of fat, the traditional technique, which is called the tram flap, has been done since the late 1970s, and it was started in Atlanta. And so the traditional tram flap, where we actually not inject fat, which is a little bit more complicated, what's called fat grafting, but tram flap, or actually transplanting tissue, has been done for many years, and so yes, those patients are extremely happy for the most part. When you look at satisfaction rates for autologous reconstruction, they're well over 80%, and the satisfaction rates hold up better over time than implant-based reconstruction. So because when you have your own fat, it's going to change with you. As you gain weight or you lose weight, it's going to gain and lose weight with you. And that's especially important if you have only one side done and you have your own natural breast on the other side. And they don't get prone to implant infections or hardening or capsular contracture around implants or ruptures. And so if you look at the data 10 or 15 or 20 years out from using your own tissue, the satisfaction rates of implants are very good too, but they don't hold up like using your own tissue. If you have a successful autologous reconstruction, the only reason you go back is to make anything like an aesthetic, or you lost a ton of weight or you gained a ton of weight. No, but there's no rupture or anything like that. That's correct. Yes.
I was told that sometimes when people have the tram flap, because they remove muscle, that you can't do sit-ups and things like that later on.
That's exactly right. I don't do the tram flap. And I'll tell you, and we get to that point a little bit, when we get to autologous reconstruction. I stopped doing the tram flap because I thought the morbidity just means, what are we leaving these patients with when we take all the muscle and the fascia? That it was too high, and so I'll explain an alternative technique that we are doing. We've been doing for over 10 years nationwide. Yes.
I have one more. I met somebody recently who had tried to do the 2-stage, and she had the expanders put in, and then her body rejected them. I was wondering how common is that?
So she asked, she met a patient that had a 2-stage expander reconstruction, and her body rejected the expander, and she wanted to know how common that is. Okay, and the body, that word rejection, it's not what it is an infection. Okay, so that's what exactly what we call, what people think may be a rejection. It's not a rejection; it's an infection. So the infection rates with tissue expander reconstruction is the same, just with implant reconstruction after mastectomy, can be as high, depending on where you are and who's doing it, anywhere between 5 and 10%. So there's a lot more going on than just say the infection rates for breast augmentation is about 1%. So it's a lot higher when you're with the mastectomy because there's a lot more going on at the same time. Okay, but yes, that's what that is infection, and it's whether even if you do a 1-stage at the same time or 2-stage, it's still there because you're still doing the mastectomy. So that certainly is a possibility. Any other questions? All right, really quick. 2-stage expander reconstruction. This is what, you put it under the muscle. There's a lot of reasons why you put it under the muscle, but the most common is you just have skin, left over after a breast cancer surgery. And so you need a little bit more to cover the implant. The more you have covering the implant, the better it looks. Implants have folds and flaws, and you don't see them in breast augmentation, or the majority of breast augmentation patients. But in reconstruction, you want to have that coverage so that it's going to look more natural, you're going to see less of the implant, and it's going to have a better outcome. And so it's placed under the muscle, and then the skin that's left over from the mastectomy is then closed over the top of that. And these are just patients, she had a lumpectomy. If you look on the top right, she had a prior lumpectomy scar, and then she's had a tissue expander placed, and she's stretched out the skin envelope, and then we come back and put in a permanent implant, a silicone gel implant, reconstructed the nipple and areolar, and did a breast lift on the other side to gain some symmetry. So the one thing other thing that most women know nowadays, but still I still see a fair number, in general, whatever we need to do to reconstruct the breast, whether it's nipple areolar reconstruction, on the other side we're going to do an augmentation, we're doing a breast lift or a breast reduction to the other side, or we do nothing. All of those are federally mandated to be covered by your health insurance policy. And so women like you and other breast cancer survivors fought hard and empowered themselves with the legislature and made that a reality. So all these things that you'll see here, none of that is, what you would say is that patients are paying out of pocket or self-pay. They've all been covered by their insurance policy. So this is another patient that had an expander reconstruction. You can see her before picture on the top left. The expanders are in place, and then we've done the nipple areolar reconstruction. We've tried to create her scars to look more like a breast lift in this particular patient, so that she doesn't have the standard horizontal scars, but an up and down scar, and try to, like I said, avoid the stigmata associated with breast cancer. So when she looks at it, she's not necessarily reminded of what she knows. She's lived through it, and she's stronger and more powerful above that, but she's not reminded of all that what she had gone through with the breast cancer. It's another one of my patients that we did a bilateral immediate reconstruction with tissue expanders, and then put permanent gel implants, did nipple areolar reconstruction. These are her befores, and these are her afters. Another patient, she wanted to be bigger, so we certainly made her bigger, but her befores and her afters. This is Florida, don't forget. So this is, I'm just going to quickly go through pictures, a right-sided cancer, and we did a mastectomy. We did implant-based reconstruction. We did a lift on the other side, and so the scar is just around the nipple here. And so these are her before and afters. And I mean, it's probably hard pressed. I don't know. I think that's pretty good. I can't really tell that she's even had cancer. And so that's really the goal, is to get to this point where when we did this, I work with I work with a whole host of surgeons at Baptist, but one of the surgeons at the Beaches Hospital, Dr. David, she was able to do the mastectomy just around the nipple areolar complex, and so we just had a little opening like this, and we put the tissue expander in. We closed it up like you close the drawstrings of a pant, and it just left a little nub of a scar centrally on the breast. And when we did the nipple areolar reconstruction, we covered them all up. So as you notice, she does not have a horizontal scar at all. It's all covered up with the tattoo. So another patient, this is a really challenging patient for me. This is a left-sided lumpectomy patient that's had radiation treatment, and I mean, I think I got lucky on this one, because this is, I think, a wonderful result from starting from here, having to deal with radiation on the left side, and we get to here, you know, I mean, remember we said we want the breasts to look better than they did before. I mean, this is certainly an easy example of, you know, I think that we made them better, and she loves them. She's happy. She's got soft, you know, natural breasts that no longer are tautic or sagging, and you know, she's back in school. Another patient, similar, you know, large breasts, a lot of skin to work with, and what we can do to try to minimize it, get them back up, and look better than they did before. Another patient, before and after, is immediate reconstruction. This is a delayed reconstruction. The patient did not have any radiation treatment, so her skin is still soft, and we can still stretch it out. And we reconstructed the right side, and we've done a breast lift the other side. And she's a great patient. All my patients are great, but she's full of energy. Her, and then I took care of one of her friends, and they go around their church and they're sharing their breast with all the women in the church. And so by the time, you know, I'm done with my career in 20 or 30 years, I think that I'll have taken care of all the ladies at that church, because they just go to the bathroom and that's it. Got to take a look at these breasts. So, you know, she for 5 years never had reconstruction of that right side. When she had her mastectomy, she was told not to have immediate reconstruction, so she did it. She listened to the surgeon, and then she went and met with the plastic surgeon 5 years ago, and he told her, well, the only way I can reconstruct you is if you remove the other breast and start fresh from both sides. And so she said, you know, I mean, I really like my other breast. It's got sensation, and, you know, it's part of me, and she didn't want to have it removed. And so she said, you know, it's not for me, and she went on to live her life, and she was happy. But then, you know, a couple years down the road, it's, you know, she's wearing the prosthesis, and it got a little sweaty, and, you know, she couldn't go on the cruises with the bathing suits and all these kind of things. And, you know, she said, you know, maybe I'll look into it again. And so I think one of the, you know, she had met with her oncologist. She's like, well, there's this new guy, you know, and so that was 2 years ago when I moved to Jacksonville. And I said, well, you know, we could just do a breast reduction on the other side. She's like, really? And she had already come to sign up for the other side mastectomy and reconstruction because she thought that was her only option. And like you say, she's one of my most grateful patients. You know, she is showing her boobs everywhere. So those are basically expander reconstructions. I'm going to talk briefly about a latissimus flap. You know, this is a flap that we take from the back, and this is, you know, in my practice, the most common patient that I use this for is someone that doesn't want something from their belly, that has had, that meet these factors, that don't want something from their belly, or is skinny and can't get something from their belly, that's had radiation treatment, and, you know, comes for a delayed reconstruction. So they've had a mastectomy, or I'll show you another example of someone that's had radiation before from Hodgkin's lymphoma. But if you've had radiation, even though the skin, you know, and I don't know if anyone's seen someone that's had radiation treatment, the skin gets burnt, and it's colored, it's darker colored, and it looks, and a lot of that heals. Sometimes the color doesn't heal, but the skin looks, you know, the burn defects go away. But the thing that never goes away is the radiation effects to the blood flow into the muscle. Remember, we're putting these tissue expanders in under the muscle, and if you put a tissue expander in a delayed fashion, meaning after it's flat, and you try to stretch that muscle, it won't stretch. It'll look like a round, hard ball. It will never look good. It'll never have a natural breast shape, no matter what you do. And if you look at the complication rates, they're over 40% for patients that have had radiation and tissue expander reconstruction. So I avoid that almost in every patient. There are a few exceptions, but I avoid that with almost every patient, because in the reality, I know I'm not going to be able to achieve what they want or what I want. You know, what we're trying to which is a soft, natural breast that is symmetric to the other side. And so for those patients, I think they really benefit from a latissimus flap. What it allows us to do is to bring, remember, you remember saying there's more skin on the bottom than the top, right? So we can bring some unburnt, unstiff skin to the bottom part of the breast, the bottom, to create that little bit of naturalness. And then we can bring unburnt muscle. And it does mean a scar on the back. And it's a line scar. It's not a big hole or a skin graft. And I'll show you pictures of it. But there is a scar on the back. And so this is what the schematic diagram looks like. You know, this is still implant-based reconstruction because the tissue from the back is not enough in 98% of the women to actually reconstruct a breast. And so this is, it still is an implant under the muscle. And so we take tissue from the back and along with the blood vessels that provide blood flow to the area. And so this is an example. Left-sided mastectomy, chemotherapy, radiation treatment, and then she's come back and says, you know, I want to have breast reconstruction. We have a latissimus flap from the back. There's the scar right there. You know, it's a little dark in here, but it's there. It's definitely there, but it's a line scar. And then we've got the skin on the bottom part of the breast, right? Remember, to create that little bit of naturalness. And then we put in a permanent implant and did the nipple areola reconstruction. We've got great symmetry. And so, you know, we've done a lift to the other side, but, you know, from starting from here and now, she looks in the mirror, there's some scars there. Certainly there's scars around where the flap was, but, you know, she's got wonderful symmetry. This is, I don't know, I've got 5 or 6 of these patients that have had Hodgkin's lymphoma at a young age. You know, they're teens and they've had radiation treatment because of the lymphoma. And then in their 40s or 50s they developed breast cancer. It's likely because of the treatment for Hodgkin's, the radiation that they had before. So remember, they've had radiation, and these patients, it's tough, like I said, with the tissue expander to get a soft, natural result. So oftentimes, I'll tell them, you know, we can try it if you really want. We can do belly, you know, if you really want to talk about what the belly is, if you want. If you don't, if you're too skinny like this lady is, you know, we can do latissimus flaps. You're going to get a softer, natural result. And this is what this is where we got. We just made the incision around the nipple areolar complex, which is just a circle, and then we replaced that circle and we tattooed over the scars, and we got a good result. Another one, Hodgkin's lymphoma patient, and so these are her befores on the left and her afters on the right, and so I think she's got a wonderful, symmetric, beautiful result. We completed the nipple reconstruction. The nipple reconstruction hides the scars. The scar was just a circle, and now it's hidden behind the areola tattooing. So I think that's wonderful. Another patient, before and after, delayed radiated breast, and we came back to reconstruct the other side, and then did a lift and an augmentation to the other side. This is a patient, came one side irradiated, and you can't tell, but this right side is irradiated, and the left side's not. Went, you know, I think she's 65, and she never had reconstruction for 3 years, and then said, you know, I really want it. And she came and saw me, and I said, well, listen, this radiated side is not going to stretch like the other side, and we're not going to be able to get symmetry. It's going to look like a ball on one side, and then a natural breast on the other side. It's not going to match. So we did a latissimus flap on one side, and no latissimus flap on the other. So we treated them independently, and it's tough to see, but the latissimus flap is right here on the right side, and there's nothing here. And I think she's got great symmetry. You know, I think that her, you know, the results before and after. You know, I think that she was a little reserved, and now she's single and 65, and she's out dancing like once a week now. I'm like, you go dancing this week? Yep. Got home at 2 o'clock in the morning, and I was like, wow. So she's having a good time now. It's amazing. I see that other patient, the lady that had delayed reconstruction and showing her boobs in church and stuff. You know, her friends that I found, she's like, oh, she's changed. Her husband told me, oh, she's changed. You know, she's now like doing all this makeup, and you know, she just feels so much better about herself that, you know, it's important to her now how she looks. You know, she's got a more self-confidence, and now she's like, well, I'm trying to exercise, I want to get my belly to be smaller, and you know, all those things, because now she feels, you know, whole or whatever it is, but she feels better about herself, and now she wants to even make it even better. And I think that's great. That's the greatest gift that I can give. That puts a smile on my face every day of the week, and I hear it a lot, so that's why I love what I do. This is another patient that had a latissimus flap. There's her befores, and there's her afters. You know, we can really try to hide scars as much as we can. Now, that's basically implant-based reconstruction. I'm going to talk a little bit about using your own body's tissue, and I can't get to it all because there's S-gap flaps, I-gap flaps, tug flaps, deep flaps, free tram, pedicle tram, but I'm going to talk about the 2 most common, Okay? And the two most common still performed in this community in Jacksonville, Northeast Florida. Yep. Yes. So, that's a great question. And so there are specialized views. They're called. The question is that if a patient has an implant placed, does it alter or hide or make it difficult to do screening tests when they go to get mammograms or other things like that? And so, so the answer to that question is, implants are placed under the muscle, and so the breast tissue is over the muscle. And they've looked at whether breast augmentation patients, whether there's any differences. They have specialized views, and the radiologists at the Breast Hill Center are trained in using what's called Eklund views to fully evaluate the breast with women that have had implants, just say for breast augmentation, and not even for reconstruction. And when they look at women with breast augmentation, and there's millions of them out there, and they've looked at studies, if you look at the women that develop breast cancer that have had prior augmentation versus patients that develop breast cancer and never had augmentation, they live just as long, and there's no higher local recurrence rate. So basically, the implant is not hiding that cancer for a longer period of time than these women, then the cat's out of the bag and they don't live as long. Does that answer your question? Yes. Well, you know, an MRI is a double-edged sword, and so she asked about MRI technology and whether its ability to detect are more sensitive. Now, if we're looking for implant rupture, the best study for implant rupture is MRI. There's no question about that. But when it comes to MRI technology for breast cancer, it's a double-edged sword. It's a great adjunctive tool or additional tool that you can use for women that have been diagnosed with breast cancer. So you've had a mammogram, you've had the diagnosis, and to use MRI to kind of fully evaluate the size and all those kind of things. But as a screening tool, meaning as a tool to look at every woman that comes to the door to see if they have cancer, it's not there yet. It's still a double-edged sword, because for just as many, or let me take that back, for the number of women that have cancers identified on MRI that were not identified on a mammogram, there's a vast majority more patients that they found something that was not anything. And so they're going for biopsies and creating scars and that whole fear. So it's not there for a screening tool just yet. Yes.
Do you ever recommend trying to remove that and have a more symmetrical feel to your breast so you can do your self-exams?
I think that it's changed, and so I don't know. I have never recommended that. I mean, I think if you cut out scar tissue, you're going to replace it with scar tissue, and so then how are you going to distinguish the new scar versus the old scar? And it's going to look different. So really, it's not necessarily you're going to feel a discrepancy there where the scar is compared to your other breast where there's no scar. But really, the question is there a change? And I tell patients, look for a change in the scar, that it's getting bigger, it's a little bit more nodular, or something like that. I think that's going to gain you more than trying to do surgery.
Replacing it with your own fat, which I have a plentiful supply. Would that be more symmetrical, or?
It may create better symmetry, yes, but for the purpose of self-examination, I don't think it's advantageous.
Also, with autoimmune issues, does that affect any of these procedures, the advisability of them or not?
I think for the majority of autoimmune diseases, most of these procedures, it does not affect it, but mostly it depends on the medications you're taking for the autoimmune disorder. So steroids has a significant impact on wound healing, and in addition to some of the immunomodulating agents, Ambrel and then methotrexate, those kind of things can help wound or cause problems with wound healing, and in those cases we may tailor the technique that we're using, or maybe just do it in a delayed fashion, or whatever have you, to make it as safe as possible. DESAI. You had a question back there in the purple hat, I think.
Using the microphone. It sounds to me like what you're saying is that after having breast augmentation, even for us who have had breast cancer, that's the answer and we go and live happily ever after?
So tell me, having breast augmentation?
After having breast cancer.
Yes.
It sounds like everything that you're saying is pro having breast augmentation.
Breast reconstruction?
Yes.
Yeah. Well, it's not for everybody, certainly. Yeah.
What about the scar tissue that builds up in us women who have keloids or scar tissue? And what is the care for these breasts after you have augmentation? And also, how long do these things last?
Yeah, so implants, they don't last forever. And we talked about ruptures, you know, that with you can, and it'll get a little bit more into it when we talk about autologous reconstruction. But implants, in general, the 1 in 4 patients have something done by year 10. So the shelf life, there's a rupture rate about 1% per year. So one out of 100 has a rupture year 1, and then the second patient year 2, and then the rate goes up by the time you get to 10 or 15 years. So if you're, you know, I see a number of patients that are 40 years old or 45, they have breast cancer, they opt for implant-based reconstruction. I tell them all, you're young enough, and I know you're going to live long enough because you're doing everything you can too, that you're going to need another surgery sometime in your lifetime if you opt for breast reconstruction. It's the same thing I tell to my breast augmentation patients, because, you know, you should expect to have a rupture sometime in your lifetime if you're that young. If you're 70 and, you know, you have 10, 15 years life expectancy, it may not be something of an issue. You know, if you're 45, it's going to become an issue. And then when you have something done, you can either have them removed and replaced, or you can just have them removed, depending on what your status is in your life at that point in time, if it's something important to you or not. Yes, ma'am. When do I not? If the health of a patient is, you know, I don't think that it's safe to actually have surgery. You know, I think that there's so many different options for reconstruction that even the worst case or worst looking, you know, chest wall, you know, they have it. So for those patients that want immediate reconstruction, that many times if they need radiation, I recommend they have delayed reconstruction. Okay. And for those patients that come for delayed reconstruction, how many do I turn away? I turn away the ones that I think are not going to be healthy enough to tolerate the surgery. And so the vast majority say, well, there's something that we can offer you, and here's 5 options, or really, you know, because of the way you're built or whatever, there's really just one option I feel comfortable doing. But I think it, you know, is an option for most women. Yes.
Yes, I was interested in hearing the response to regarding keloids, because many, especially people of color,
Absolutely.
do keloids. So what do you find occurs or can occur or help in terms of reconstruction or augmentation?
So in any keloids in surgery, it's a trauma to the skin, and you get a keloid. And so it doesn't matter whether it's augmentation or tummy tuck or, you know, gallbladder surgery. If you have a keloid develop and your skin is prone to that, we don't know what causes keloids, and so we have basically one of 3 options: leave it alone, okay, to cut it out, and inject steroids, to just inject steroids, and then, you know, there are some cases where you can remove it and do some localized radiation treatment. And the most common things are maybe like an ear that's really recalcitrant, and it's really important, and we can focalize the area. The more aggressive you are, the lower the recurrence rate, but there's still not something in any of those options that gets rid of it 100% of the time. Even with the most aggressive, which is removing and radiation treatment, it still comes back about 25% of the time.
So that means that reconstruction and or augmentation may not be an option for women who tend to keloid?
Well, it means it is, you got to determine whether the keloid is worse than not having a breast. And so that's what's in the balance there, right? If you were a woman that you knew were, you know, definitely going to get a keloid, then you have to, what's more important, the scarring that's present, and likely you probably had a mastectomy, so you probably have a keloid already, you know, if you're talking about reconstruction, you know, and you've got a horizontal keloid. So can we get that keloid under control? And if we can, then can we try to do the same thing we did to get it under control to have reconstruction at that time? And then it's whether to have a breast or, you know, or to have a keloid. Doesn't mean that it's not an option. It's just you have to weigh that into your decision-making, you know, algorithm or tree to say, you know, what's more important to me. It's the same thing I talk to women who want brachioplasty. You know, the wing that's kind of behind. You know, you get a scar that's from, you know, the elbow up into your arm that's right here. And so, you know, I tell them, what's more important to you? Do you want to get rid of this, or do you want to avoid the scar? And when they say, you know what, I don't really care, I'm okay with the scar, I just don't like this thing flopping around, that's when it's right for that patient to have surgery. Yes?
Thank you.
Are keloids preventative or what causes them?
We don't know. Okay? It's it's an inflammatory reaction that your body, it's kind of like an immune response. Your body creates inflammation at the area of trauma, and the reason we haven't figured out is that we don't really understand. So we have a few treatments that we've tried, but we don't know the true mechanism of what creates keloids. We know that the inciting event is trauma or a cut.
I have a question. In regards to a boob weighs a little bit. You have certainly have big boobs. How does that affect like rotator cuff, severe traumatic arthritis in the shoulders? Does it hinge on it, or?
It shouldn't affect the rotator cuff. Now, reconstruction and the expansion process can be uncomfortable, and it can sometimes, when we get to the full volumes, limit range of motion, and we often get these patients to work with the physical therapy that helps these women maintain their range of motion and all those kind of things.
Well, I've been advised that I need a total shoulder replacement, and I was just wondering if, you know, this heavy boobs affect weight on the shoulders.
It could. I don't think, I haven't seen a patient that has ever complained of, you know, limiting their shoulder after they've completed the reconstruction. I have seen patients with expanders in during that expansion process, because it's quite firm, that have had limitation or right after surgery. But long term, I haven't seen it cause rotator cuff impingement problems. But I haven't taken care of it. Well, I have one patient that's had complete shoulder replacement, and she's doing well. Yes.
To go back to what you were saying about having to have your augmentation replaced after, I guess, 10 years, would it just be better than to use your own tissue, then you won't have to replace it?
That's a decision for every patient to make. That's what's important, is that they are told that they have these options, and these are the advantages, and these are the disadvantages. That's one of the advantages to not using an implant, is that you don't have to have it replaced. But that's a personal decision. It's not my decision. You know, you can say, well, have a scar somewhere else when you use your own body's tissue. And so one patient would say, you know, I don't want to have that scar. I'd rather have the implants replaced in 10 years. And the next patient will say, you know, I'm okay with the scar. It's hidden pretty well, and I don't want to have implants. And so it's variable from patient to patient.
Well, I have so many.
Yes.
Can you speak a little bit to the safety of implants, about what's inside of them and leakage into your body and those?
I think it's a great question. I get that a lot. So she asked about the safety of implants and, you know, what's inside of them. There's two types of implants. There's saline and silicone gel implants. And, you know, obviously we've had saline implants around for a long, long time. The silicone gel implants came back onto the market a number of years ago, probably I think about 7 years ago now. And the silicone gel implants got taken off the market because there were studies that they thought that caused autoimmune and lupus. And basically, when they critically looked at the data, remember, companies got shut down and a lot of lawyers made a lot of money. My wife's a lawyer, so I can say that. Companies got put out because of this controversy with implants. Down Corning went out of business, and they basically made some, from looking at the data, some false conclusions. Now, the silicone gel today is better than it was then. I mean, I just took one out yesterday. It was all liquid, it was like a liquidy. It was still intact, the shell was, but it was a liquidy silicone. Now it's a cohesive gel, so it's cross-linked to itself. So if you cut it in half and hold it upside down, it's not going to even fall on the floor. So it's not going to leak into your bloodstream. It can cause reactions locally at where the leakage areas are that typically is removed when you remove the implant that's ruptured. And but the FDA obviously didn't just take, after the fiasco in the 80s, take it lightly to reapprove silicone gel implants. And if you're worried about it, you still have a great option of saline implants. And if it ruptures, the salt water just goes away. And so, but both, I believe, are very safe. And one thing is, the most studied medical device in the history of the world is the breast implant. So not your stents in your heart, and not, all those other things that you can think of, your valve or anything. It's the breast implant. Yes?
I talked to someone recently who said they had an implant that was silicone on the inside with saline on the outside, and
Yes.
she felt that was a safer implant.
Yeah, it's called a Becker type implant, or it's a tooth shell implant. They're trying to get those back, but they're not. They had them. They took them away when the silicone kind of went away, and then they haven't really created a structurally sound one. It hasn't come back out yet, so it's not available currently. Yes.
I have a question for, before you get to the reconstruction phase. If you go for your mammogram and then your doctor detects something then and there, and then offers you maybe radiation therapy or chemotherapy, what exactly does the radiation do to the breast? Does it dissolve the cancer, burn the cancer out, and how does that chemotherapy work?
Okay, so the chemotherapy is it's drugs that are given through the IV that are used to infiltrate the entire body to try to target the cells that are rapidly growing, which are cancer cells. And so it's trying to limit the cancer in general. Breast cancer is a systemic disease. Even though it's localized to the breast, those cells are everywhere, and so it's trying to attack it everywhere. Radiation is to attack it just in the breast, and so it's focused on the breast, and it tries to get local control. So chemotherapy is there for those patients that say, I recommend chemotherapy. They're recommending chemotherapy to increase the likelihood of their survival. And radiation, when they say, oh, I recommend radiation, that's used to increase the likelihood or decrease the likelihood that the cancer comes back in that breast. Not survival, but local control or local recurrence. Remember the oncological safety we talked about, survival and recurrence. So those are, in a nutshell, one's for survival, one's for local recurrence.
Okay, so it doesn't actually remove the cancer.
The radiation does kill cancer cells. It kills a whole host of other tissues. But in essence, if you suppose you had a cancer that was this big and you removed it, by blasting with radiation, it kind of takes all these the area around it out too. So it's increasing, the area there, so they can kind of have a little bit of a better local control for the area. Yes.
What does the radiation do to a person's reconstruction that they've had, or whatever you call breast augmentation? What does the radiation do when you have that in and they have to give you radiation?
The radiation is significant, so it affects all types of reconstruction. It significantly, for the negative, it alters and makes reconstruction worse, and worse with implants than with your own tissue. But it affects both in a negative fashion. Let me just go and take 5 minutes to talk about autologous reconstruction, so you've heard about it, and then we'll open the forum up for questions. So, autologous reconstruction using your body's own tissue. See a patient here, a capsular contracture, hardening around an implant. These are, like you were asking me before, well, is it better than just to use your body's own tissue? Well, she's pretty skinny, so it'd be unlikely. But back to your question of pedicle tram and not doing able to sit-ups, this is why I don't do it. Even though the pedicle tram, the tram operation's faster, you don't have to do microsurgery, you have higher rate of complications, you can't offer it to as many patients, you lose all your muscle strength, and even beyond the muscle, your fascia, which is kind of holding our organs in. So the hernia rates are quite high with patients that lose all that fascia and have to have it reconstructed with mesh. And the pedicle tram is basically you taking the skin and fat from the belly, and obviously the benefits of using your own tissue are multiple-fold. It's going to gain or lose weight with you. It's never going to rupture. The infection rates are way lower than implants, and if it gets infected, you just treat it like any other infection. Give some antibiotics, open up the area, and let it heal up on its own. The other added benefit is that you get a tummy tuck with this type of operation, right? So you lose the skin and fat from your belly. So that's a very attractive thing, and that's why this operation was done in millions of women probably in the 80s and 90s, because when it came out, well, you get a tummy tuck and you get a reconstruction of your breast, it was great. But the problem was the breasts looked good, but you got so many problems with the belly. So we worked on developing newer things, and the one that I now do, and I now abandoned the pedicle tram operation, is a DIEP flap. These are all acronyms, and I'm not going to go into what they stand for, but a DEEP flap or a DIEP or a DIEP flap. It basically takes the skin and fat, but it doesn't take any muscle or fascia. It takes these tiny little blood vessels that come up to the skin and fat, and then we remove it. And as opposed to kind of tunneling it under the skin, we remove it and hook it up to new blood vessels via microsurgery. Because it's tiny blood vessels, the blood vessels we're hooking up are about 1 millimeter in size, so the end of a ballpoint pen. We need the microscope. There's a little bit more expertise involved. It takes longer. But you see these patients. I've seen patients go home, on day 3. They're walking. They can get up out of bed. They're pain. I just did one, she was smiling in the recovery room. She's like, I don't have any pain. And so she was taking Tylenol, and that's on one end of the spectrum, obviously, and I'm just the best case example. But she was a tough lady, and but she was able to start walking, and the next day after surgery, and she went home, after 2 nights with having a tummy tuck and a reconstruction and a breast lift on the other side to get match, and looks like $1 million. So with a DIP flap, you have all the advantages of using a pedicle tram. It's your own tissue. It's going to gain or lose weight. You have a tummy tuck. There's no muscle that's taken, and because the tissue is detached and then reattached, and there's nothing tethering it like a tram, you take the skin and fat, and then you have this muscle that's tethering it. So you can only twist it a certain which way. Because of the DIP flap, you're disconnecting it and transplanting it, right? You can position it where you want. So you can position it more in the inner part of the breast, the inner upper part of the breast, to create better cleavage. Because remember, we talked about one of the goals of breast reconstruction surgery. So this is a patient. She had a left-sided mastectomy, and we did an immediate reconstruction. These are her befores above, and these are her afters below. She does have a scar below. You can look at her belly. The small, she's not that big of a lady, but the small amount of pooch that she had is gone now, and she has a reconstruction. You can see the scarring right around here, and then we've done the nipple areolar reconstruction on the left side to match the right side. It's another patient. She had cancer on the left, came back and developed cancer on the right, opted for